description of the vaccines, developing the vaccines, and then my efforts to create a COVID-19 vaccine for the Philippines. So first of all, the pandemic in the Philippines. So the best way for me to talk about the pandemic is to show you this pandemic curve. So a pandemic curve on the vertical axis talks about the number of cases, total cases reported on a particular day. And then you've got the horizontal line, which is the timeline since the beginning of the pandemic a year or so ago. And you can see that there have been two surges in the Philippines, one that peaked at the beginning of August and one that we are still coming down from. It was a peak that overwhelmed us, kept us busy, kept my days and nights full for basically 2 months from March into April. And the reason why it kept me awake and kept us awake, those of us who do pandemic management, is because what happened is that surge overwhelmed the hospitals in the capital. So these are just snapshots from a newspaper at the peak of the curve. And you had COVID patients basically parked on the floor, both inside the emergency room and on makeshift tents outside the emergency room on cardboard boxes, because our hospitals were overwhelmed, and they were overwhelmed for about a month. Now, to give you a sense, I think the way I did this is I am comparing this to the pandemic curve for the United Kingdom. So in red, you see the pandemic curve for the United Kingdom. And for those of you who are in the United Kingdom, you can see that you had a surge, pretty much a third surge at the beginning of the year, which has now gone down. It's even below the curve for the Philippines. This is primarily driven by the vaccinations that have been ongoing in the United Kingdom for the past several months. But notice the difference in absolute numbers. So we were overwhelmed at 10,000 cases per day, while the United Kingdom was able to tolerate a massive daily caseload of over 60,000 in a day, while the Philippines was not even, there was no way we would have been able to do that. And I would like to talk about why this is the case, and why understanding the pandemic and doing pandemic ethics really depends upon the particular circumstances of the society at hand. So these are the unique challenges of the Philippines with regards to the pandemic. About 60% of our homes are intergenerational. What this means is we do not have any retirement homes. We do not have nursing homes. All of our senior citizens live with their children and their grandchildren. Now, the challenge this posed on the country was enormous. So to shield our senior citizens, basically my mother, who is 80 years old, has not been able to leave our house in 14 months. It is illegal for her to step outside of our gate. So anyone who is 65 years and above has not been able to leave his or her home for 14 months. First thing. Second thing is anyone who is 16 years and below has not been able to leave the home in 14 months. And the reason for this is, even though young people are at low risk for severe disease or hospitalization, they would bring the virus home and infect their grandparents. So Filipino society had to impose restrictions, which from I know my American friends are considered incredibly draconian, that our senior citizens and our young children, our young people have not been able to leave their homes, not even to go for a run, not even to go for a walk for 14 months. Next thing, 44% of Filipino families own a refrigerator. You can imagine what challenge this would pose if you go into lockdown. Because if you go into lockdown, especially a lockdown that lasts several months, you need to feed people. And if they don't have a refrigerator, there is an added challenge of trying to figure out how to feed them. Metro Manila, which with a population of about 13.8 million people, has the highest population density in the world. And that has caused some problems, challenges for us, because some of our informal settlements have been hubs for COVID-19. 16.7 Filipinos live below the poverty line, which means that it's very hard for them to go into lockdown because they have no source of income. We have 7,000 islands. So each one of these, this is a strength and a weakness. So a strength is that there have been islands where COVID has not yet entered those islands. But the weakness, as you will see, is when it comes to vaccination, we're going to have challenges getting the vaccines to these islands. In terms of our healthcare, there's one doctor for 33,000 Filipinos. And I just wanted to contrast that in the UK with the national health system, it's one to 360 residents. And in terms of hospital beds, there are 5 hospital beds for 10,000 Filipinos. And you can see that that is the United Kingdom has 5 times more the number of beds. The United Kingdom has 68 million people. The Philippines has twice as many, just to give you a sense of the relative population. Another thing I would like to discuss is subsidiarity. So subsidiarity for the Catholic moral tradition has been it's a cornerstone of Catholic moral tradition, where the common good is managed by the level of government that is closest to the challenges at hand. And what you see in the Philippines is that the Philippines, we run our healthcare system at the level of the barangay. The barangay translated could be like a village. And so it's not surprising for the mayor of a city in the Philippines to become president of the Philippines, because the way that our governance structure is set up is we are really a country of cities. And then the cities are divided into these villages, these barangays. And so in terms of pandemic management, I spend a lot of my time talking to mayors, especially in the National Capital Region in Metropolitan Manila. There are 17 cities in Metropolitan Manila, and trying to organize them and get them together on the same page with regards to pandemic management. So how I'm doing this is I'm a member of an independent and interdisciplinary modeling and data analysis team from the University of the Philippines, that's UP, and the University of Santo Tomas, that's UST, the number 1 secular school and the number 1 Catholic school in this country. And I belong to the faculty at the Catholic University of the Philippines, the University of Santo Tomas. And what we do is we do modeling and data analysis for the national government, for the president and his cabinet, and for all lower levels of government, primarily cities, and sometimes for the villages below them. So I spend an enormous amount of time on media. So these are frontline just recently about our work from CNN Philippines, different media outlets. I also have to go on TV a lot in order to explain the pandemic and to explain why we're doing certain things so that people will understand the challenges that we're facing. And every week now I write a column for one of our online social media sources in order to explain COVID-19 to the Filipino people. And most recently, this week, what we're trying to do is we're helping the government to redeploy vaccines. So the government has not yet, until today, this morning, the government announced that they will be redistributing vaccines based upon geographical region. And that decision was supported by modeling data that we presented to the government last week, where we wanted to model the shape and the intensity of the pandemic, depending upon if you vaccinate the capital first or the capital and the 2 other major cities first. So there were different combinations and scenarios of vaccination that would allow us to, in a sense, optimize the scarce vaccines that we have. I'll be talking about that scarcity in a few minutes. So things that I've learned that have ethical implications. So first of all, I discovered that pandemic management is about protecting the healthcare infrastructure of a country. So a lot of people in the West have argued that the case fatality rate, the number of people who die from COVID, is very similar to, say, seasonal flu, maybe just a percentage point above seasonal flu. It has never really been about death. It has been about the healthcare infrastructure of a country, and therefore indirectly death. So again, go back 2 months ago in April here in the Philippines, we had people dying of COVID-19 while waiting in their cars in front of the emergency room of a hospital. We had waiting lists of 2 weeks to enter a hospital. Now, most of these people survived, but the tragedy of it all is that when your healthcare infrastructure is overwhelmed, as it was in the Philippines, people who have other illnesses, people who have other health challenges are also dying, not from COVID, but because they did not receive the care that they received. Second point, this is controversial in the West, but it's clearly, it works here. Lockdowns work. They work. That's the only thing we could do to shut down the surge that we were having in March. We had to go into lockdown. And I think the United Kingdom has had that similar experience, especially with the new variants. The transmissibility was so high, simply masking, simply social distancing, isolation, tracing, contact tracing, all of these testing and contact tracing. It was simply, we tried for 1 month to keep it under control, but we just couldn't do it. We had to go into lockdown. But there are tragedies for the poor and the vulnerable. I've discovered, because I have to go on TV a lot, the government has to either counter the government, support the government. Public communication relies primarily on trust rather than on truth. What I mean by that is people will believe whom they trust, and they really do not determine whether or not what they're hearing is true or not. And I think this is because of the cacophony of voices in social media. There's just too many people talking. You can't tell what's true. You can't tell what's real. So everything is trust. And then this is, as a Dominican, as a Thomist, this was also surprising. Public communication is really mostly about emotions rather than reason. This is rhetoric, of course, but it's rhetoric to the nth degree, especially with trying to get 112 million Filipinos to try to alter their behavior in particular ways to prevent the transmission of this pandemic. We've had to rely on all sorts of things. An ethical question that I'm going to raise for this group is, what is the relationship between the common good and the individual good? So the classical Thomistic tradition has always looked at the common good as having a primacy over the individual good, because both of them are ordered towards human flourishing. And yet more people are involved in the common good than there are in the individual good by definition. And yet in the West today, you have numerous arguments, especially among Catholics, that the individual good trumps the common good no matter what. Moving now to vaccine confidence. So at the end of January, my research team here at the university deployed an open access social media survey around our country. We got about 15,600 responses. We wanted to ask, were people willing to get the vaccine? We got 56% saying, yeah, they probably were going to get it. But more important, this was also a survey that wanted to interrogate vaccine hesitancy. So what you have here is that Filipinos have concrete concerns about COVID-19 vaccines. What is so striking is, unlike, I'm sure, in the UK and in the United States, the number one concern was fake vaccines. Again, this is so shaped by the culture in this country. We also noticed that Filipinos are much more worried about their families than they are about themselves. Again, unlike some polls released from the West. And we noticed too that unlike Westerners, Filipinos are strongly influenced by those around them. So 77% agreed that they would receive the vaccine only after many other people receive the vaccine. And 71%, again, I think this is unthinkable in the United States, in the United Kingdom, they would only receive the vaccine after politicians receive the vaccine. And this was a sign not of trust, actually, but distrust. They wanted the politicians to be vaccinated so that the Filipinos would see that the vaccines are in fact efficacious and safe. So this led to the development of a vaccine awareness campaign. We were going to provide the Filipino people with truthful information to mitigate their specific concerns. We wanted to emphasize a collectivist mindset. You need to vaccinate not just to protect yourselves, but primarily your families. And we wanted to provide Filipinos with testimonies of kababayan. So kababayan is the Filipino word for those who live in the same house as you. These are countrymen. So other Filipinos, kababayan, those who live in the same house. So what we did is we set up here at the university a COVAX response. It's primarily undergraduates. So I have a team of undergraduate students, primarily bio majors with a bunch of arts majors. And what we do for the last 3 or 4 months is we've been preparing infographics that presents the science and biology of the vaccines, both in English and in Filipino. And we flood social media with these in order to help our fellow Filipinos, our kababayans, to understand what's going on with the vaccines. And then in a unique way, we provide what we call COVAX-19 testimonies. So we have selfies now of hundreds of Filipinos with testimonies of why they got the vaccine, and we send that all over social media, and Filipinos like seeing other Filipinos who've been vaccinated. And this has now led to what we have. The current issue we have is vaccine envy, actually, not vaccine hesitancy. And that's an interesting dimension of collectivist society. I was just speaking to a mayor of the largest city in our country this afternoon, and vaccine envy is the thing. I don't think there's vaccine envy in the US at all. So again, general observations for possible conversation later. Cultural forces shape vaccine hesitancy. And I think we knew this, but we are now beginning to get a sense of what these forces are. I've noticed that fear shapes the human intellect more than truth, but love conquers fear, which is why here our public awareness is all about you're getting vaccinated because you love someone. We acknowledge it is scary. We acknowledge that it generates fear, but we're asking our fellow Filipinos to love more than fear. We've also noticed that though we provide arguments for the efficacy and effectiveness of vaccines, the stories of people receiving the vaccines have been much more important for our vaccine strategy. And then of course, friends preach more effectively than strangers. And a question that I've raised here in this context is, which virtues drive vaccine confidence and which vices trigger vaccine hesitancy? So in the last part of my presentation, before we have our conversation, I just like to talk about the vaccine challenges that we have here in the Philippines. So this is the coronavirus vaccine tracker from the New York Times. Basically, take-home message, there's about 100 or so vaccines somewhere along that's somehow being developed in the world. 4 of them have been abandoned, including one from Australia, actually. The University of Queensland, they had to abandon one of the vaccines that they were developing because they were using an inactivated HIV vaccine delivery system. What this means is that they were using parts of the HIV virus in the development of their vaccine. And during testing, they discovered that people who were vaccinated with their candidate vaccine, even though they did not have any active HIV in their bodies, were actually testing positive for HIV. And so they had to abandon the vaccine in order to protect the HIV testing program that we have around the world. But you can see now we have basically 15 authorized or approved vaccines throughout the world. I'm sure you've heard of many of them. So there's Pfizer, Moderna, Gamaleya, AstraZeneca, and in the Philippines, we have to use the Chinese vaccines, Sinovac as well. And we will talk about why that is the case. So just so that in case you're not familiar with how the vaccines work, the basic idea is that antibodies destroy SARS-CoV-2 and vaccines help your body to make antibodies. And this is a very famous picture. I think her name was Maggie. Maggie was 90 years or so in the United Kingdom. And she was the first person vaccinated outside of a clinical trial. Excuse me. And she was vaccinated at the end of December. Now, vaccines are actually vaccine delivery systems. So they're going to deliver something to your body. And what most of these vaccines do is they deliver the spike protein. So this is a picture of the virus. And you can see that the skin of the virus is covered with about 70 to 75 of these spike proteins. And these spike proteins are the key that the virus uses to enter your cells. And so your body, we are training your body to recognize this virus-specific key in order so that you can fight the virus before it overwhelms your system. There are 4 vaccine delivery systems at this time. So the most famous ones are Pfizer and Moderna. These are the RNA vaccines. What these vaccines do is they deliver the information for that spike protein, and the spike protein is made in your cells for a day or so, and your body recognizes them, recognizes spike protein, and is trained to mount a defense. The viral vector, this one here is AstraZeneca and Gamaleya. So these, what you have is you have a monkey vector, the adenovirus vector, and you put the information for the SARS-CoV-2 spike protein. And so the monkey virus carries the information for the SARS-CoV-2 spike protein into your body. You also have whole virus. These are the Chinese vaccines. These are inactivated, killed SARS-CoV-2 viruses. They are injected directly into your body. And then this is the protein subunit. This is Novavax, which is still in final stages of clinical trials. Now, these are the 3 major vaccines that we use in the Philippines. I'm sure in the UK you have primarily AstraZeneca. I'm not quite sure in Australia which ones are being deployed. But you know, a lot of people can compare the efficacy. But what I would like to point out is that the effectiveness of these, so efficacy is clinical trials. If you've got 40,000 people in your clinical trial, what percentage of them are protected against COVID-19? Effectiveness is actually, you would vaccinate people in Indonesia, you vaccinate people in Brazil, you figure out of the hundreds of thousands of people who are vaccinated, how many of those get sick. And one thing that is striking is that the effectiveness of these vaccines are actually higher than the reported efficacy. That's the first thing. And I need to highlight that the protection against severe disease and hospitalization is nearly full protection. And I don't think people realize that from a public health perspective, we don't care if you get COVID, as long as if you get COVID, you don't go to the hospital or die. So if you get COVID and you have sniffles, or if you have COVID and you're in bed for a day, it doesn't matter. What's really important is you cannot go to the hospital, because that will overwhelm our hospital system, and it is likely therefore that you will die, which is why any vaccine that is 100% or near 100% effective at protection against severe disease and hospitalization will be an effective tool for ending the pandemic. I also highlight here the two fetal icons because these are two of the vaccines that were developed using cell lines that were obtained from the remains of an aborted fetus. The Gamaleya was from the Per-C6, Johnson & Johnson Per-C6, Gamaleya and AstraZeneca from the HEC 293 cell line that was isolated in 1972. So talk about the safety of the vaccine. So as of this morning, 1.7 billion doses have been distributed globally. This is really important to understand. So a lot of people are concerned that the COVID-19 vaccines shortcuts were taken because they were developed in less than a year. And I think for you to appreciate the challenges of developing a vaccine, you have to understand that there are two obstacles to successful vaccine development. One, lack of funds. So a lot of people who are making vaccines spend a lot of time trying to get money. That was not a problem this past year. The second is that if to test your vaccine, you need to wait for an outbreak. So let's say you're developing an Ebola vaccine. Well, you have to wait until the next Ebola outbreak, which could happen 7 years from now. And then you rush over to the Congo and you vaccinate people in the village or surrounding villages around the outbreak. So it takes 10 years on average in order to develop a vaccine, simply because most vaccines that are being developed are for rare diseases. This was not a problem with COVID-19. There was an infinite amount of money that was thrown at vaccine developers, and two, you could go out and get vaccinated. You could basically go out and find people who are at risk of getting the disease outside your lab. Second thing you need to know is that, so safety profiles. A lot of people are asking, how will we know how safe these are? Well, safety profiles for vaccines depend upon the number of people who've been vaccinated. To give you an analogy, or a comparison, the yellow fever vaccine, which we routinely use if you travel to Africa or many countries in Asia where yellow fever is endemic, has been administered in the last 100 years to 600 million people total. As of today, there have been twice, if not near two, twice as many people have been vaccinated against COVID as compared to yellow fever. Now, why is this important? Because once you have numbers of people, you can identify rarer and rarer side effects. You can identify rarer and rarer adverse events. So if you have 600 million yellow fever vaccinations, you are limited to side effects that will occur in more than 1 in 600 million. What you're seeing now with 1.7 billion vaccines is we have a very, very good profile, safety profile of these vaccines, simply because there are so many people who've been vaccinated, and a few people who have rare genetic constitutions that will make them respond to the vaccine in a different way from the species norm will now be able to be identified. Now, in terms of side effects, so I'm not sure how many of you have been vaccinated, but most involve 2 doses. The second dose is always more difficult than the first because the side effects are a response of your body to the vaccine. So this is me receiving the second dose of my Moderna vaccine at the end of February, and I pretty much had all of these except nausea. And another thing you should know is the younger you are, the worse the side effects, because again, the side effects are a response of your body, and the younger your body, the more robust the response. Third thing you should know is that I follow up. So there are a lot of senior citizens who have no side effects whatsoever because their immune system is a lot more tepid. And even though it does work, they don't mount that vigorous response. Third thing you should know that we've discovered about these vaccinations is if the first dose is worse than the second dose for a person, it is more likely than not that that person actually suffered from asymptomatic COVID earlier in the pandemic, and the first dose is acting like a second dose with regards to the body's immune response. And so I just point out, they're a sign that the vaccine is working. Now, the risk of blood clots for AstraZeneca is extremely low. So a lot of people have been complaining about AstraZeneca. Just to give you a sense for blood clots, so the blood clots is 1 in 250,000, so it's 1 in 250,000. The risk of being hit by lightning is 1 in 15,000, and the risk of being in a car crash is about 1 in 100. So as I explained to people in the Philippines, if you are willing to take the risk of walking outside during a thunderstorm because you don't really think that the risk of being hit by lightning is great, then you shouldn't be worried about AstraZeneca. One thing too, there are hints that the blood clots from AstraZeneca may be linked to the birth control pill. That's still a very controversial but very real possibility at this time, which is why it's primarily younger women who have been facing this challenge of blood clots. Now, the COVID-19 vaccines in the Philippines. So you may or may not know that there's a significant vaccine shortfall in the world. So you can see there, these are number of doses. So in the first half of 2021, there were 7 billion doses made. Now keep in mind that there are approximately 7.5 billion people that require 2 doses. So we've just not had enough. Now next year, the year after, we should have plenty. But one of the things that's really striking is that you have a few countries pretty much hoarding most of them. So if you look at the number of doses, these are the reservations. These are the supply agreements. These are countries who have reserved doses. So the European Union has reserved 4.3 billion doses. The United States has reserved 3.26 billion. And the United Kingdom has reserved 569 million. Now, what I've done here is doses per citizen. So the United States has reserved approximately 10 doses of vaccine for every American. The United Kingdom has reserved 8.4 doses for every British citizen in the United Kingdom, where you only need 2. So basically, there is an excess of 6 doses for every British citizen that is not available for the rest of the world. To give you contrast for the Philippines, we have been able to secure 1 dose per citizen, where remember, you need 2 doses for full vaccination. So this is the inequity that you see around the world. Canada is the worst. So Canada has reserved 16 doses for every one of its citizens. And there are reasons for this, but basically it's hoarding. You know, I'm just gonna make sure I have extra in case I run out. This is the whole, you know, at the beginning of the pandemic, people were complaining about toilet paper, and toilet paper was being hoarded, and everyone got really upset that people were hoarding toilet paper. But it's a tragedy that no one's worried or complaining about the hoarding that we see with regards to vaccines. Vaccines, I would propose, I hope you see, are more essential for the livelihoods of billions of people than toilet paper. So we've had to resort to getting vaccines from everywhere and anywhere we can get them. And this is our challenge. So we will have to vaccinate 75 million people. Basically every single Filipino adult, because we have 30 million young Filipinos. So every adult, 7,000 islands, we have to vaccinate most of them twice within a month because we do not have any single dose vaccines at this time. You have to do this in a country where only 40% of families own a refrigerator, where power outages are frequent, especially during the rainy season, which is beginning in 2 weeks, which will last from now to the end of the month, end of the year. So these are the challenges that we face. In order to respond to that, I've asked myself the question, my research students and I are working on a this should be shelf-stable, inexpensive oral vaccine for the Filipino people. This is actually an image of the vaccine delivery system. So we took a human probiotic yeast and we genetically engineered it so it will produce the SARS-CoV-2 spike protein. So you will drink the vaccine delivery system, and this yeast will live in your intestines for about 3 days. And while it's in your intestines, it will pump out SARS-CoV-2 spike protein. And the hope is that this will trigger an immune response in your gut. So we won't need doctors, no nurses, no injections, no refrigerators, and it's relatively inexpensive. Maybe $2 a dose right now is the target. And my students are going to call it, we've decided to call it the mini-vax. 2 reasons why it's the mini-vax. One is it's a vaccine of the Lord, Domini-vax, but it's also because I'm a Dominican and my students are working at 2 Dominican universities. And so these are 2 of my students. These are 2 of them back home in the States who are currently working on this, and I'm supervising it on Zoom. So we have engineered the yeast and we are testing it. We will test it here in the Philippines. So just general observations. We need an ethical account of hoarding. It's quite striking. When I bring up the vaccine hoarding, Catholic scholars in the United States will say, it's not hoarding, it's prudence. So it's prudence. So the question now is, where are the boundaries of prudential action and vicious hoarding? So, what is hoarding? Why is it vicious? What are the ethics of vaccine choice if this can only occur because of vaccine hoarding? So if vaccine hoarding is an evil because it's an injustice, then what does this say about people's desire to be able to choose amongst vaccines? Because you have to keep in mind that in order for you to have vaccine choice, the government has to provide for surplus vaccines because they're not sure which vaccine a particular citizen is going to take. In the Philippines, there is no vaccine choice. You get what you get because we don't have extra. But if you get to decide between Pfizer, Moderna, AstraZeneca, Johnson & Johnson, in many ways, the government has to put this choice into its calculations, which will lead to an excess of vaccines needed for the government to procure. And in a time of great scarcity, what does this say about vaccine choice? We need an account of global common good. So I've heard people argue that countries are like families. So government should be able to think about their citizens first and foremost. So, and the World Health Organization has pointed out, yes, this is true, but to a point. Is it just that children who are at very low, if not infinitesimally small risk of severe disease for COVID-19 are being vaccinated by their countries when senior citizens and medical frontliners who are at incredibly high risk are not being vaccinated in their countries? So the question is, when does it actually become vicious that vaccine nationalism is all about us and not, it's all about us, but not global us? And if this is the case, who's responsible for this good? Now, that finally, with regards to vaccines, of course, we have the universal destination of goods in the Catholic moral tradition. And when you're desperate, someone else's bread will be your bread when you and your children are starving. Well, does this also follow with regards to vaccines and other privately manufactured goods during a public crisis? Is there common ownership of these vaccines? How does this impact our conversation about patents and the intellectual property rights that are associated with the goods that we commonly use in our culture today? So So finally, this is just the slide that I usually end on. It is a blessing from the Lord that we have these vaccines, that they were ending the pandemic in the UK, and we hope to end the pandemic here a year from now. And again, the notion of common good. We have to be vaccinated, not just to protect ourselves, but to protect our neighbors as well. Thank you very much for your kind attention.
And thank you very much, Father. That was very interesting and important talk, and I'm also very impressed at the research that you're carrying out as we speak. So definitely all the best for that. So I'll just throw open if anyone has any questions. You can just
any thoughts, comments.
Yes, just a couple of questions, if that's okay. Yes, thanks for a very, very interesting talk. Yes, I mean, I've got several, but I don't want to hog the floor. So, so maybe just starting with the virtues and vices and vaccine hesitancy. I mean, it's not always going to be the case that it's a vice leading you to be hesitant. You might, for example, be a pregnant woman. You might be a young woman who says, well, you know, we're not completely sure about effects on fertility. You know, there have been reports of miscarriages following vaccines, and the vaccine reporting system isn't infallible either. So not everyone who miscarries is going to be reporting it. So she might say, well, I'm not at much risk myself. You know, maybe she doesn't live with elderly parents or whatever. She does have to think of her children, and that's her being virtuous, I would have thought, not vicious. And plus the fact that if she turns it down, then the vaccine's available for someone who's medically vulnerable, someone who's a lot older than she is. So that was the first suggestion. So
the question now has to do with the intellectual virtues, right? So let's deal with the intellectual virtues. So how much, so for example, the claim that the vaccines trigger miscarriages, I have no, these are anecdotal. There is no evidence in my mind, and there's no biological mechanism for this. So the question now is, you know, so I understand her concerns, but does she have, what intellectual virtues must she practice in order for her to critically engage with all the information she has out there? And so she hears anecdotal stories of a miscarriage in the 1.7 billion people. She has, you know, she hears maybe 10, right? So the question now is, what sort of intellectual virtues are in play where she's being prudential, right? So is that being prudential, where if you hear about 10 cases in a 1.7 billion, you then take that risk and you have no sense of putting that risk into perspective? Does that make sense?
Well, of course, she has to put the risk into perspective, but it's not just sort of personal anecdotes. She may hear from the self-reporting, you know, not just in the UK, but in America as well. You know, there are. Many women will be thinking
the self-reporting. You know, I can go on there and put anything on there. This is the thing that boggles my mind as a scientist, is that the VAERS system is such that anyone can put anything on there. So the question now is, she as a person is looking at the VAERS data, and she's hearing experts and scientists explain to her that there is no risk, and yet she's willing to trust this unverifiable reporting system, right? This is what I'm asking. What virtues, is that a vice? Is that a virtue?
But isn't this some kind of very rough data for scientists? I mean, isn't this scientists getting the feedback? As in, you know, we've got to look at the number of people who miscarry anyway. That's absolutely true. But unless people feed back the fact that, look, I lost my baby, unless that gets fed back to the scientists, then we're all in trouble, because we've got to know what groups are at risk of having the vaccine and what groups aren't. So
no, it's true. But I think what I'm wondering about is, again, right? So the scientists have said will say to her that there is no data, there is no mechanism for this. Miscarriages. So one of the challenges that I think is difficult for non-scientists to understand is that we're dealing with numbers, right? So I have people who tell me, I heard that someone died after being vaccinated. And the challenge there is that on average, there are going to be people who die every day.
Of course. Yeah.
So when we calculate the numbers, we have to ask, is the probability of having a miscarriage after the vaccine higher than the average miscarriage rate that you would expect for people, this number of people in this certain period of time? And we don't see that, right? This is why it's so, and yet I have had people tell me, well, you're just lying. I've had people say that scientists are hiding the truth. It is, and I'm just trying to wonder what the intellectual virtue and vice is there, where people want to hear what they hear. I've had people email me who have explained to me, and this is a housewife who has done research online, and she will tell me that clearly the vaccines will make her infertile if she gets close to someone who's been vaccinated. So it's not even that she's vaccinated. If she breathes the same air as someone who's been vaccinated, she's going to miscarry. Now, she explains this to me, and she's gone through online. She's done the research. She's talked to people. There are scientists who say this. So it's very intellectually, I'm struggling to try to understand what the intellectual virtues are in our culture and Western society at this time that's generating this incredible sense that I, as a non-expert, am just as qualified as anyone else to evaluate data. And it's very strange to me.
Yes, no, you're absolutely right, that there's far too much self-confidence out there. But at the same time, the fact that because we've been facing a pandemic in some countries, it's hit much worse than others. You want to be sure that in their keenness to protect as many as people as possible, that public health authorities are sufficiently responsive to signs that there are particular groups, who perhaps shouldn't be vaccinated, maybe very, very frail elderly ones, maybe people in hospices. A friend of mine recently, a friend of hers got very ill after the vaccine, and her doctor was very dismissive, and she's still feeling very ill, and she hasn't reported it herself because she's not well enough. She's sort of struggling to look after the kids and so forth. And I just wonder whether at a time of pandemic, there's a temptation to think that everyone's fear-mongering because there's so much misinformation around and so much excitability and so forth. But there will be some people, who are experiencing problems, and the question is then to listen to them, to not to assume it's unrelated.
No, I agree. I think that what you do see sometimes is you do see people who are very dismissive of some of the claims. And I think one of the things that's interesting is, so for a biologist, the question is whether or not there's a possible explanation for why the vaccine could trigger the symptoms. So for example, the AstraZeneca blood clotting, the reason why that was taken so seriously, which is why there's such a big concern about that, is precisely because there was a way where the vaccine could trigger that. And which is why scientists will go, that even though it's rare, it's 1 in a quarter of a million, and it happened in a very small group in Denmark initially, and that people were willing to focus in on that because biologically there was a plausible explanation for why A could cause B. So one of the challenges is that, for example, with the pregnancy and the miscarriage, we can't imagine, there has never been a situation where a vaccine would trigger of this kind against a respiratory disease would trigger a miscarriage. So I think, and I think the challenge that public health officials, especially scientists, have to do is it's so hard to communicate this kind of information to lay people. That's one. Number two, and I think this certainly in the Philippines, the science is changing so quickly that people don't appreciate how quickly it changes. And to say that it changes is not to say that we lied to you, that it's just that it's changing. And so the data is changing, and we're trying to make as informed a prediction as possible.
Yes. I might add, Father, something that might help as background in the UK. The updated advice for pregnant women has actually been largely based on the US study, whose that you mentioned, whose methodology is based purely on the self-reporting, and so that there has been some skepticism about that method that you raised, and it's been largely positive. It's been saying that the vaccine is safe for pregnant women, but that there are if you have COVID, there are risks of increased risks of stillbirth and so on, and so I think it's the case where I like what you called intellectual prudence there, would maybe make you have to engage with those the methodology of those studies and the way that they're being employed by the government, and in particular, as Helen mentioned at the start, to assess the risk of you getting COVID for your baby versus the risk of you being vaccinated for your baby. But it's a very interesting case because it brings together something of what you were talking about. There's the collective concern there for the mother and her child, You
have other questions, Helen? You always have such interesting, thought-provoking questions. I love reading your stuff and thinking about the stuff that you write. For this reason.
You're so kind, Father. I feel bad now. I'm hogging the floor. But well, the next one actually was I've got one that I'll save till the end, but if there's time. But the next one was really about on the other side, about the benefit of vaccinating those who when it won't affect asymptomatic COVID. And I'm just wondering about the long COVID. Because long COVID's a nasty thing that can happen with asymptomatic COVID.
So what's striking is that there are reports now, and again, these are not yet confirmed, that vaccination resolves long COVID.
Oh, no, that's yes, that's very interesting. Yes.
Right. So one of the things we think is that long COVID is residual SARS-CoV-2 in your body that the body just can't get rid of. And so when you are vaccinated, what actually happens is the boosting of the immune response allows the immune response to go in there and clear out any residual virus, resolving long COVID. This was an unexpected result that is awaiting confirmation. So for example, one of my students has not yet been able to recover his smell after 4 months. And there was a paper that came out a few weeks ago that suggests that the reason why you don't recover your smell is because SARS-CoV-2 remains in your nasal passages, inflames that tissue, and it's that inflammation that prevents you from recovering your smell. So the idea is he went in for his injection, his shot. We're waiting now to see if once his immunity builds, his body can go in there and clean it up, and he gets his smell back. So the hope is that long COVID can be resolved in that way.
Yes, well, that's very interesting. I was thinking more of that as a reason for younger people to get vaccinated. But if the vaccine's better at protecting hospitalisation and death, will it be any good preventing these cases of long COVID, many of which come from asymptomatic infection?
So again, the hope is that if it can clear residual COVID, then that would help long term, right? So now, one of the things too you should know is that the data is pointing out now that when you're vaccinated, it's especially with the mRNA vaccines, it is unlikely that you will even become asymptomatic. So the reason why the masking requirement has been lifted in the United States is that the data from Israel pretty much shows that once you're vaccinated, you're not only protected against getting sick, you're protected against getting infected at any level at all. And if you got infected, it's so low, you can't even give it to someone else. So this is called sterilizing immunity, not just effective immunity. So our hope is that all of the vaccines will actually do this. The reason being, so just a little biology, the reason why there was always a concern is that when they give you a shot, the vaccine is injected into your muscle. And so your body develops an immunity, but the mucosal membranes of your nose don't get that immunity. And so the virus can get in there and they will grow in your nose. They can't enter your body, but they grow in your nose. What we're seeing now is that the RNA vaccines are able to produce an immune response even in your nose. And the hope is that all the vaccines, because even though you're vaccinating your arm, will eventually lead to protection in your nose, which will mean the pandemic is done.
Oh, that'd be wonderful, but
other questions?
I don't want to hog the floor, so anyone else before I
think
have another go.
If one of the, just going on the question of vaccine uptake, one of the concerns that some people have, and it's sort of been expressed in various ways here in Australia, is that there may be coercive pressures applied to take vaccines. And I wonder what that does to the sense of trust that is necessary for. So there's seem to be two ways to go. If you move into the territory of coercion, that has almost a kickback effect, or a reactive response, where people go, well, I might have actually taken up the vaccine, but if you're going to really force me to do it, I might dig my heels in. That might be a peculiar Australian thing, I don't know, but
no, I think it's a very Western thing. I think that would be a concern in the United States as well. Yeah. I don't know if it would be a concern in the UK, but I think it would be a concern in the United States. Now, it's interesting because we already have coercive vaccination policies, right? So yellow fever, again, just to give you a perspective, no Filipino can leave the country without a yellow fever vaccine passport. So the government here, so many third world countries have coercive vaccination protocols precisely because it's the only way to protect the common good against yellow fever. So you cannot leave the Philippines without a yellow fever vaccine. You cannot return to the Philippines without yellow fever. Even if you're a Filipino citizen, you are not allowed to come in. We do not have religious exemptions. We do not have conscience exemptions. It's a very striking framework in a profoundly Catholic country. We don't have those. And we don't have those because of the strong collectivist mindset, right? So the very strong collectivist mindset, you are leaving the country, so it's a privilege for you to leave the country. You got to protect the people who are home, so you got to get vaccinated so you don't bring it back home. So, you know, it's again, it's like if you're in a family, if you leave the house, you got to make sure you don't bring a plague back home. So that's a very strong collectivist mindset. Many third world countries have coercive vaccination policies in place already. And in fact, there are Westerners who travel to developing countries who are coerced into being vaccinated. So you can know British, if you're British, but you go through an endemic yellow fever country, you cannot enter the Philippines, doesn't matter. And the way the Filipino people will understand this is, you're coming to our home, we are poor, you have a responsibility not to bring a pathogen to our home. So we're gonna make sure if you are coming to visit a poor person's home, you have to make sure that you don't bring something that would cause them illness. You see the collectivist mindset, there's not this, it's forcing me, it's like, you're a guest, we are poor, we don't have a healthcare infrastructure to deal with a COVID yellow fever pandemic. So if you want to come visit us, you need to get vaccinated. So again, it's a very different cultural mindset. When people bring this up, I go, I am concerned about that in the West, I really am, but it's striking because here it's not a concern at all. It's already in place.
And it's not in place for COVID? Sorry, is that in place for COVID yet?
Not yet, but it is, I'm involved in conversations. I am trying to, the government is inching there very slowly. We don't think we need to get there as long as we get to herd immunity or at least containment. And we have enough vaccine envy at the moment that we don't think we have to go there, but it would not be a problem for us to go there in a way that I think it would be a problem in Western countries if their governments decided to go there. I mean, what's the debate in Australia about vaccine passports?
At this stage, I don't think there's much of a debate at all. It's, our vaccine rollout has been quite slow. And so the uptake is sort of inching along. There's been some conversation at the fringes about vaccine passports and concern over it. And I think I get the feeling that the government is treading carefully to see what happens and hoping that it doesn't have to get into that territory of mandating anything. But I think that part of my concern, at least in the Western context, is the question of trust. And I think that's something that, I mean, I'm a physiologist by background, and so, you know, that working through those, to the biology of things is okay for me. But I do know that there are so many diverse opinions around, to a certain extent, even amongst scientists. And once there's that diversity of opinion amongst scientists, you know, or either that or a sense of mixed messaging coming from the government strategies to deal with the pandemic, that then trust gets eroded. And once trust is eroded, things like vaccine uptake are affected as well. So I agree with you.
And I mean, at least for the United States, there was already no trust prior to the pandemic. So because of the depolarization of the country, so the pandemic just exacerbated that completely. But it's striking here in the Philippines, the Filipino people don't trust their government except for this. And I think the view is we can't do this alone. You see, so it's very clear that an individual Filipino cannot end the pandemic by himself. And if we want to end the pandemic, we've got to do it together. So again, it's an interesting mindset. In the West, at least in the United States, there's not the sense of we need to end this pandemic together. I think people just assume the pandemic will end, but they don't see themselves as being part of the solution to end the pandemic in the way that the Filipino people, we have songs that we sing to fight COVID. We have an oratio imperata that is said at the end of every mass in the country to end the pandemic. It's an entire, the common good is so visible. We can only end the pandemic together. You don't have that sense in the States. I mean, my friends are not saying, let's end this pandemic together. That's just, the pandemic will end, somehow it will end, but it's not, I'm not part of the solution, it doesn't seem like. How does it seem in the UK and in Australia?
Well, I think in the UK, certainly, you know, the NHS, it very much pushes the message of, you know, this is about all of us, and, you know, do your part, and so on and so forth. So, you know, to what extent that's accepted on the ground is another question. But in a way, I suppose, yes. I mean, it's good to call on people to take a collective approach and be responsible and think about, you know, the country as a whole and so forth. I suppose the danger is that a particular approach, even if it's not scientifically backed necessarily, or even if there's controversy about it, will then get taken up. And I'm sure you're familiar with the research of Stanford University. People suggesting that at least with some countries, it seems that sort of voluntary self-isolating seem to do the same kind of job as having laws about it. And, you know, looked at North Dakota and South Dakota, and they had similar rates of COVID, even though one had mandatory lockdown and the other one didn't, and so forth. So I think, I suppose there's a temptation if you're a public health official to give a very, very simple message, you know, much more simple than the science can actually back. You know, and then, you know, you can overdo the skepticism as well, and but perhaps a little more honesty along the lines of, well, you know, we're following the science as best we can. We are listening to things as they come in, you know, and not to sort of overplay things. I mean, do people accept the kind of thing you were talking about? You know, months and months and months of not being able to leave your house, for example, because, you know, that would be seen in this country as
impossible.
Yeah, impossible. I mean, you know,
Impossible.
Yes, yes, and you could argue, well, that if that's made a legal imposition, rather than government saying, you know, if you're very frail, you might want to stay indoors for a good bit. If that's made a legal requirement, you know, yes, I mean, are you justified in doing that? I mean, you know, if there's a terrible disaster, perhaps, but
it is illegal to leave your house. You
illegal
can
to
be
leave your
arrested.
house. I mean,
here to do that, and it's precise. And again, it was, you know, the explanation has always been it is to protect our grandparents. Now, what's really, really striking is that in this country, in a way that I cannot see in the United States, the grandparents are the most important segment of Filipino society.
Mm.
They hold the memories of our culture. They are the ones who will teach our children about what it means to be a Filipino. So they are the treasure of the nation, right? So in many ways, we will do everything we can to protect them in a way that unbelievable. My friends in the United States just absolutely cannot imagine that the children of our country, and I have colleagues who have not stayed at home with their parents in a year because they do not want their parents to be sick. So they put a cot up in their office and they say hello to their parents through the gates of their house. You know, they can come in, they say hello. The parents are in there with their grandkids and they're out there and they Zoom. But it is unbearable for the Filipino people to risk decimating our senior citizens is unthinkable. We will go through anything, and which is so, from Western culture, I think is so you can't think it. You know, once you're 60, you are gold.
Yeah, I mean, it's wonderful that you've got that kind of attitude, but I just wonder if only for the person themselves. I mean, I can imagine being a 60-something or 70-something in the Philippines saying, well, look, I'd rather take my chances. I'd rather leave my house, go for a walk. You know, why can't I take my chances?
Again, you see what would happen there is the Filipino grandparent would go, if I go out and I get sick and die, my grandkids will never have the privilege of having me to be with them. You see, it is never self-referential. It is all, this is thing that so a Filipina for a grandparent would always see it that way. So it's not a, and so they will take, now what will happen is you have incredible resilience, because what will happen now is you're doing this for love of someone else. So, and as you know, love can allow you to tolerate so much. So what's happened is a grandparent, I know of a grandparent who was thinking of doing that. You know, she wanted to go to walk in a mall after a year. And, you know, and her kids were like, we'll drive you in a car. And then she was like, my grandkids, you know, my apo, what happens if they lose me? What are they gonna do? You see, it's a culture that is so profoundly different with regards to seeing the self as important as an individual, as a part of a family. And what we're trying to do now, to be honest with you, is and so one of the things I'm trying to do is we're trying to get our fully vaccinated senior citizens out of their homes. Now the challenge is this whole vaccine passport thing. You have to show that you have been vaccinated, and it's very easy to fake and Photoshop a card. So part of the challenge is, how do you have a system that allows people to prove that they've been vaccinated so they go out? My mother is going to be vaccinated hopefully this week. And, you know, within 6 weeks, I'm going to say, Mom, let's just go out. Let's just go out to the mall and we'll just go out. I asked my mom, I say, are you okay that you haven't left the house in 14 months? She's totally fine, you know, and she goes to the daily mass on TV every day. Her girlfriends will talk to her on Zoom. When she has food, she has supplies delivered to her by family members. It's a very strange mindset when you encounter it after living 30 years in the West. It's just very different.
Are people not concerned about, you know, I mean, that's wonderful that your mother is taking it so well, and many other people as well, I'm sure. But are people not concerned about things like depression, obesity, you know, all sorts of problems you can get by being, you know, home alone for over a year? I mean, not everyone is going to have a loving family right there.
True, again, but remember, most of these grandparents are living with their grandkids. So we don't have, most of our senior citizens are not alone. In fact, they're surrounded by their family members. They've got three family sets of grandkids with them, because what usually happens is the sons and daughters will send their children together to their grandparents, and they live together. They've been living together for a year.
Okay.
So then the adults go out and work. So it's a very, the structure of the family is just so different. I mean, that's why we have no nursing homes. We have no old people homes. There's just none of that because the structure is so different. Now, I understand it's very similar, for example, in some southern Mediterranean countries. Some people have told me, like Italy, you have similarities, but I'm not sure.
Just related to that, Father, one thing you said in your talk that interested me very much was about tailoring your engagement with vaccine-resistant populations, and the fact that has to be adjusted. You spoke a bit about your social media work, which was a very targeted attempt. Now, what I really got from your talk is that there's two aspects to that. So it's a movable feast, as it is. On the one hand, you have to very much know the culture that you're dealing with, because you won't be able to convince British people in the same way as convincing Filipino people. And on the other hand, you have to keep a constant track of the kind of vaccine resistant information that is being produced at like an incredible and spread at an incredible speed that we're not used to dealing with. So the latest hoax or the latest worry. You know, I had some very sensible friends of mine sharing worries about the RNA vaccines, you know, going into your DNA, even though there's no reverse transcripted, like there's, as you said, there's no mechanism for that. So, you know, these even intelligent people are obviously, you know, keeping abreast of trying to put fact aside from fiction and trying to work through all the information. And so what I was wondering is what you think is the best approach, given that vaccine resistance is a very dangerous thing if we want to achieve herd immunity. It's like a big barrier in every single country. What you think the best approach to that is, in terms of like, is that something that it should be a kind of bespoke country-specific team of social scientists? Should it be a kind of like collaborative team where you have some people who are going to be literate enough in the kind of online hoax information? And, you know, just I wondered, like, because obviously it's very good to flood social media and like that seems like a really good approach, but it seems like a need which is going to be changing very fast all the time.
So I think that it's going to have to be culture specific. I think that the things we're doing here will not work in the United Kingdom, precisely because the messaging is going to be different, because you're dealing with cultures that are different, value systems that are different, virtues and vices that are different. With regards to the misinformation, it is astounding to me how much there is out there. Number one. Number two, I think, you know, much of this misinformation is very hard to decide if it's true or false, because most people don't have the background. So for example, the RNA vaccines, if you heard that the RNA vaccines could possibly interfere with DNA, it's actually plausible. It's actually plausible. So if you're not a biologist, it is plausible in your mind. And the question is, you don't know who to go to answer that question. That is the challenge we have. Now, the UK, I know one of the things I read is that the UK has there's a center that brings together scientists and they provide informed opinion for the media. So I've read that regularly, actually, just to see what the UK is doing. We don't have something like that yet here, but I would think that is something where, can you find legitimate sources of information? But I think it's, as Greg pointed out, right, trust is so hard to come by. And so, especially in the United States, it's not whether you're a scientist, it's whether you're a Republican or Democrat that counts. So people will live in their bubbles, and it's very hard to penetrate those bubbles to get right information to them. I'll give you an example. I mean, many of my close Catholic friends in the United States, they would consider themselves traditional, conservative, are deeply, not just hesitant, but are actually anti-vaxxers for reasons that they believe are Catholic in nature, and that no government should be able to impose any healthcare decisions on them whatsoever, right? So, and what has happened is they have conflated their American rugged individualism with what they perceive to be Catholic theology. So when I talk about the common good, it befuddles them. They've never heard of that. They usually focus on conscience rights, conscientious objection, which is very big. And there's a legitimate place for this. Have you guys seen that new essay that is going to be published in the American Journal of Bioethics, where the argument is being made that the abortion doctors can conscientiously object to any law that limits abortions? So they're now, because as you may or may not know, the Supreme Court of the United States has agreed to hear a case from Mississippi in this coming year that potentially that could potentially, if not in de facto, but de facto overturn Roe versus Wade. And so now there's an argument that is being made that a woman, an OB-GYN who is a woman who believes, she has a deeply held belief that abortion should be a woman's right, should be able to provide abortions even if the law says it is illegal, because she is conscientiously objecting to that law, right? So here you have this very, very strong notion of conscientious objection, which was always been linked to just and unjust laws, right? So there was always the case that conscientious objection was there to protect the virtuous intellect from an unjust law. But now, in the absence of any common standard of justice, what we're now seeing is that conscientious objection in the West is basically, I disagree with the rest of you. So what we're seeing in the United States is I have very close Catholic friends who are using this same notion of conscientious objection to basically say they object to everything. And this is why I'm asking, can we recover the common good in some way that is intelligible to the modern day 21st century Western liberal view? I'm liberal as in the liberal values that come from John Locke and his successors.
Yep.
May I ask?
Go on quickly, Ilaria. We're just going to.
Yeah, very quickly, because my question was, frankly, do you think that Western governments are really interested in the global common good? Because as far as I can see, USA, UK, Canada, there is this so radicated individualism that people are much, much more interested in their personal freedom instead of common good. And when we think about common good in the COVID pandemic and the vaccine, maybe you can think about the fact that if you get a vaccine, you can protect your grandmother, but you don't go farther than that. So if the government secure an average of 10 doses per citizens, it means that even the government is not really interested in the global common good. And so I was thinking, if all the poor countries are interested in this global common good, and if this is the case, there is no choice that, because all the vaccines, comes from the Western. I think the Western is not interested.
Well, I think I would say it's not Western necessarily. I would say it's wealth.
Wealth, yeah, the richest country.
Rich countries don't worry about the common good because they have enough for themselves. That's what you're seeing. The poor countries, because they know they cannot survive on their own, are thinking in a collectivist mindset. Now, to test this hypothesis, you can look at a country like Korea or in Japan, which is collectivist in nature, but is relatively wealthy. And what you see there is you do see less of the Western view and more of the collectivist view. So, so mask wearing, for example, in Japan and in South Korea is prevalent even before COVID, because mask wearing was a sign of courtesy. If I am sick, I will wear a mask because I don't want you to get sick. Again, you know, that has been very alien. My friends will say, I will wear a mask if the mask protects me. If the mask doesn't protect me, then why am I wearing a mask? So, and this is part of the debate in the United States. We had to say that it's primarily not about protecting you, it's protecting others from you if you were sick. And this, in the individualism of the Americans, which they chafed against that. They really didn't like that. So I would say when you don't have anything, you want people to share. When you have everything, you don't want to share. And I think that's basically what you're seeing now with regards to the common good. Now, the reason why I bring this up, especially in the forum of Catholic scholars, is because in many ways, the church, you see, the church has a role to play in this.
Yes.
In a sense, the church is the one who should be the standard bearer for the global common good. She does not have any power. She has no political power, but in many ways, the church is a unique position to speak about this good. Now, the Pope has been trying to speak about this good, especially with regards to vaccines. But I don't even see the United Nations as being an effective instrument for this, because the Security Council is set up so that the members of the Security Council will look out for their good. They will always look out for their good. So this is why in a way that we have to be imaginative, the church has to assume some role, a prophetic role of talking about this global common good and trying to institutionalize it in some way for the sake of the poor.
Yeah.
That's a excellent note on which to end, Father Nicanor. I think like you've said that very well. And you know, we can only hope that that does become the case and we can contribute to that. So thank you for giving us this discussion. I'm sure we could be questioning you all day, to be honest, but you've got far more important projects to be getting on with there. So
well, I just
thank you very much for your time.
Thank you.
I just want to thank you for doing what you guys do. You know, there has to be more of this, of friends speaking and challenging and listening. And I've learned, you know, I've spent the last 30 years of my life in the States, and to be in lockdown in my homeland for a year has been incredibly eye-opening. And I've tried to convey some of that to you, the deep cultural differences. And in many ways, I understand the Catholic vision of the world better in this culture than in the American culture. I don't know if that makes sense to you. Like in a culture like this, where we talk about, where it's profoundly pro-life. So our Constitution protects against abortion and things like that. When we talk about the elderly and we talk about the poor, so I think I didn't mention to you that in our priority list, the poorest of the poor have precedence over the rich and the middle class. So we have A, B, and C in our priority list. The poor are in the A class right after the economic frontliners. We have 19 million poor, and they will be getting the Pfizer vaccine. So the government has designated the best vaccine will go to the poor. The Chinese, the British, these are all considered, I'm not saying anything about AstraZeneca, but the Pfizer and the Moderna are considered the best. They are being designated for the poor. The poorer you are, the more likely you will get inoculated with Pfizer or with Moderna. This is unthinkable in the States. I do not know, I mean, that the government mandates this, right? That the best vaccine is put aside for the poorest has been heartwarming. I mean, I understand now what it means to say there is the privileged, we talk about the preferential option for the poor. When we speak about a society doing that, I understand that now for the first time in my life, what it means on the ground, where the government will prioritize the poor. They will give them a higher priority in the vaccination scheme, and then they will reserve the best vaccines for them. I mean, to me, that's like, wow. That's what a pro-life country should be, right? And it's not just about abortion, it's about the vulnerable, the elderly, the poor. And that's why I wanted to kind of share that with you and to thank you for doing what you do in the countries where you serve. And I hope that this presentation at least made you see the world in a slightly different way, in a way